Hello, everybody. We're going to get started with our next session. If you could start filtering in and taking your seats. Also, if you're speaking in this session, if you could just make sure that you're easily accessible so you can make your way up to the stage quickly when it's your turn, I'd greatly appreciate it. My name is Danny Engel, and I'm an assistant professor at the Salk Institute, and I'm really excited to be co-chairing this session together with Dr. Wu. And we are ready to get started with our first speaker, Dr. Anirban Maitra, who's going to be giving his talk virtually through a pre-recorded video. And he is going to speak to us about the early detection of pancreatic cancer.
Good afternoon, everyone. My name is Anirban Maitra, and I'm a professor here at the Perlmutter Cancer Center at NYU Langone Health in New York City. I would like to thank Dr. Belen, Dr. Saluja, and all the APA annual meeting organizers for the opportunity to speak today, and would also like to thank them for the flexibility in allowing me to send this pre-recorded talk. I'm so sorry I could not be there in person. Now, today in this session on early detection, you're going to hear in-person talks from Dr. Brand, Dr. Lennon, and Dr. Mojumdar on various aspects of high-risk individuals and biomarkers. So my goal today is to set the stage for the rest of the session and give you an overview. So one of the things we have learned is that improvements in survival for pancreatic cancer have almost entirely occurred in the localized disease setting. We have seen that every year there is a progressive improvement in survival. When I started my career, it was about 4%. It is now 12 to 13%. But much of that has come in patients who have localized disease, as you can see here on the left side of the panel. In advanced disease, because of the availability of FOLFIRINOX and gem-nab-paclitaxel, even though the one-year survival has improved over time, and you can see that in this line here, the 5-year survival still remains dismal and in low single digits. So again, it's the localized disease setting where much of the improvements have come. And that's not a surprise necessarily when you look at the remarkable heterogeneity of metastatic pancreatic cancer, which is what most patients present with. In the study we published on spatial transcriptomics and clonal architecture in advanced disease earlier this year, you can see that in two synchronous metastases of liver mets from the same patient obtained at the same time, there is remarkable diversity in terms of the clonal evolution and dynamics. These synchronous lesions look nothing like each other, even though they're in the liver at the same time in the same patient. And that complexity is reflected in the disparate therapeutic responses we see in patients with advanced cancer. In work that was published a few years ago from MD Anderson using pre-diagnostic samples from the PLCO repository by Johannes Farman and others, we see that there is a elevation of CA19-9, which can be seen in the blood starting somewhere around 18 months prior to the diagnosis, and there's a sharp uptick that happens in the last 6 months preceding diagnosis, suggesting that there is an opportunity, a window of opportunity for earlier diagnosis if only we knew who to look for in terms of these signals. And the other piece of data I wanted to highlight is a small retrospective study from the Mayo Clinic by Suresh Chari that showed that in patients who were diagnosed with pancreatic cancer, if they had incidental radiology done for some other reason, and you went back with the hindsight of knowing that these patients had pancreatic cancer, you would see that the resectability of the disease dropped pretty sharply in the last 1 year to 6 months prior to diagnosis, again showing that there is a window. It's not a big window, but there is a window. If we can identify who to screen and who to survey, then there's a possibility of earlier diagnosis of pancreatic cancer. So the question that we often get asked is, why not screen everyone more than 50 years for pancreatic cancer? Why not do this like we would for prostate or colorectal cancer, for example? The answer to that is there's a reason why the USPSTF, which sets screening guidelines for various cancers, gives pancreatic cancer screening in the general population a failing grade of D, like do not screen, because not only will you not help, you will actually cause harm. And this is a slide that I obtained from Brian Volpin. And it really nicely captures the dilemma of screening everyone for pancreas cancer, which is that even if you had the best biomarker, your ideal biomarker that actually currently doesn't exist in reality necessarily, and you screen the general population, because the frequency, the prevalence of this disease is still relatively uncommon, the positive predictive value, the PPV, which means when the test is positive, it is actually saying that somebody has the disease, is actually very low. It is in the single digits. And for the PPV to get into a level where it is both fiscally justified and ethically justified to screen individuals with imaging studies or other invasive procedures for pancreatic cancer would require us to screen a population where the prevalence of this disease is much higher. And so the key word here is enrichment of the general population for those who are at higher risk of either harboring an occult pancreatic cancer or at higher risk of developing pancreatic cancer over their lifetime. So, who are these high risk populations? And do we know them? And the answer to that is yes. So, there are three broad categories where we have some clarity on high risk for pancreatic cancer. These are individuals with pancreatic cysts, individuals who have hereditary risk for pancreas cancer because of germline mutations, or because they have multiple family members. And Dr. Brandt and Dr. Lennon will talk about this in their talk, so I'm not going to focus on that. And the third category is individuals who have new onset diabetes. Adults with new onset diabetes for the first time do have a higher risk of pancreatic cancer. And this is the category I'm talking about. I'm going to talk about a little bit more as I move forward. And this is the utopia. This is where we want to go. This is a slide from Johns Hopkins, from Ralph Ruben, showing an incipient cancer in a high-grade IPMN. And this is really what we want to get at, to catch the cancer before it becomes invasive. So a few years ago with Randy and others, we wrote this commentary on a roadmap for earlier detection of pancreatic cancer in collaboration with our colleagues at the NCI, the Early Detection Research Network, or EDRN. And this defines the who do you screen for pancreatic cancer? This is the high-risk populations I just talked about, the ones with family history, new onset diabetes, and mucinous cystic lesions like IPMNs. The how, what are the biomarkers we can use? What is the performance we are looking for that is ideal? And then where is it? The where is it part is also very important, and that refers to the imaging that we need to make sure we get better at, because obviously the human eye, as you saw from the Mayo data I presented, does miss these smaller cancers in particular. The other unmet need here is this big chunk of the pie, which is individuals who are at sporadic risk for pancreatic cancer. Now, remember, the ones who have familial lesions or genetic alterations or cystic lesions, they only still comprise together about 20 to 25% of cases. Three-quarters of individuals, as every gastroenterologist or surgeon or oncologist in the audience today knows, is somebody who comes in with no obvious reason for having pancreas cancer. So for this sporadic risk population, this is where mining the EMR or electronic medical records and using AI to identify patterns that might identify those who are at higher than average risk, and then putting them on surveillance programs is going to be pivotal. And there's a lot of activity going on in the field right now using AI, developing and implementing AI-based models for enriching the general population for those who are at higher than average risk. Now let's talk about the hyperglycemia and diabetes that precedes pancreatic cancer diagnosis. This is the seminal work of Dr. Suresh Chari. Those of you who were present during the first day of the meeting obviously heard Suresh talk about this complex relationship between diabetes and pancreatic cancer. But in work that he did when he was at the Mayo Clinic over almost 15, 20 years, he really showed that patients who were diagnosed with pancreatic cancer, the vast majority of them had at least some glycemic dysfunction, if not frank diabetes, that occurred many months before the onset of cancer symptoms that we know to be typical of pancreatic cancer. And this has now been validated in multiple retrospective studies. Some examples I've shown here, including work from Brian Wolpin and Wendy Setyavan and Beechin Wu. Even in algorithms, AI-based algorithms that have identified those at higher risk for pancreatic cancer using EMR, even in those papers, we see diabetes often rises to the top. Now, this diabetes does not specify whether it's new onset or long-standing, but as far as I believe, much of this is actually reflecting the effect of new onset diabetes as a risk factor that's showing up in the pre-diagnostic phase of pancreatic cancer. In fact, Tomas Gonda from NYU, I think he's in the audience today, also identified that new onset diabetes is a biomarker of progression in pancreatic cancer precursor lesions like IPMN. So this truly is a harbinger of cancer in the blood. And because it's so easy to measure, either using glucose or HbA1c, this is truly a biomarker that can be used in the sporadic population. And the other thing that Suresh and others have shown very nicely is that this is not just an endocrine dysfunction. There is also associated exocrine dysfunction, and that work from Matt Vander Heiden and Brian Wolpin and others has also really codified this nicely. And these patients often have muscle loss and adipose tissue loss that can actually be picked up on radiological scans when you're looking for body composition analysis. So again, we think of some of these phenomena like muscle and adipose tissue loss as late stage cachexia findings, but they can actually start showing up much earlier in the disease and again be a diagnostic feature of an underlying occult cancer. And in fact, last year in a commentary that we wrote with Suresh, we came up with this term called pancreatic cancer-induced metabolic dysregulation syndrome, or PDAC MDS, really highlighting that this is a systemic metabolic dysfunction that accompanies pancreatic cancer, and it happens early in the disease, not just in late-stage metastatic cancer. Suresh may have talked about this, but I just wanted to reinforce again that in this recent study of almost 19,000 individuals followed prospectively through EMR-based diagnosis of hyperglycemia, the REGARD study, this is now published earlier this year in Gastroenterology. What we find is that there is an almost 8-fold higher standardized incidence rate, or SIR, for pancreatic cancer, especially in white non-Hispanic populations. This number is lower, this risk is lower in other ethnicities. And again, this really highlights the importance of knowing the population you're working with. This again is reflected in that in this graph here, where approximately 0.84%, just a shade under 1% of individuals who have new onset diabetes, who are white non-Hispanic, develop pancreatic cancer within the next 36 months. So on average, if you use EMR-based glycemic new onset diabetes, so this is not the clinician giving a diagnosis, but this is a single elevation of HbA1c on a blood test that is seen in the EMR, and that acts as a trigger. That trigger, EMR-based trigger of what we call G-nod, a glycemic nod, can lead to a median lead time in diagnosis about 8 months, which could be the difference between resectability and not. So based on all of these findings, Suresh and Lynn Matrisian from PanCan and several others wrote this very nice review our commentary, I should say, really, it's not a review, more of a commentary, where we came up with a new term called heuriskins. And this comes from the word heuriskine, meaning to find or discover. And I wanted to highlight this to really highlight the difference between the way we traditionally think of surveillance for lifetime future risk of pancreatic cancer, which is what we do for cystic lesions or patients with familial risk or germline mutations. And again, you'll hear about this from Dr. Brand and Dr. Lennon and Dr. Majumdar. That kind of prospective follow-up of early detection, which is the traditional way of looking for development of pancreas cancer, is different from this particular situation where you have new onset diabetes that is being caused by the underlying cancer that is already there. So this is not a future development of cancer. This cancer is already there. It's just not manifest itself, but the new onset diabetes is acting as a trigger that allows you to find or discover this cancer that you would normally not have. And I encourage you to read this commentary. It's a new way of thinking about what we would call an opportunistic earlier detection of sporadic pancreas cancer, somewhat distinct from the traditional longitudinal surveillance methods we think of. All right. With that said, I want to come back to how we are doing surveillance for pancreas cancer in high-risk populations. And I'll end with that because I think interception is being tackled by Dr. Lennon in her talk. So early detection of pancreatic cancer in high-risk cohorts is still mostly passive. When we have these patients who come in and they have a germline mutation or a cyst, we image them, maybe we do a blood test and we say, well, come back in next year for another imaging test or whatever. But can we do something to block cancer from happening? And as this really nice data from Mike Goggins, who kindly shared it with me, shows, this is a person who has a PALB2 germline mutation, has innumerable pancreatic cysts. What do you do with someone like this? You know that this is a ticking time bomb in the pancreas that will develop pancreatic cancer. On the right side of the panel is again data from Mike showing RAS mutations in the pancreatic juice that you can detect in these patients. You know that over time they will develop cancer. So can you stop that cancer from happening altogether? And this is where we are in a new era, and you heard probably a lot about KRAS at this session, at this meeting, as well as posters. So we now have a lot of orally bioavailable KRAS drugs. There's this really interesting paradigm that's being proposed by many groups, including our own Tomas Ganda at NYU and others, saying maybe in the patients that they are following for early detection, we could use these orally bioavailable KRAS inhibitors for intercepting pancreas cancer. And this has been shown in the context of mouse models. This is a paper that was published by Raghu Kalluri from MD Anderson last year or earlier this year, showing that in these genetic models, if you give KRAS inhibitors, you can block PANN progression. This has now been shown by other groups as well. So this is really a very exciting time, and we can actually start thinking about primary interception of pancreatic cancer in those who are at high risk. So with that, I would like to come to the end of my talk. I want to thank my colleagues at MD Anderson and my new family here at NYU Langone, in particular, Tomas Ganda, Paul Oberstein, and Manny Hidalgo. Really amazing things happening here in Midtown Manhattan, and that's a view from our conference room. So thank you all very much, and I'm grateful again for this opportunity to present.
Okay, thank you for the first speaker. Now we are going to have the second one would be Dr. Randall Brand. His talk will be early detection of pancreatic cancer, heredity, predisposition, and pancreatic cyst lesions. Let's welcome.
Well, I want to thank the organizers for giving me the opportunity to speak today about a topic I love. It's always tough to follow up someone like Anirban, and before that, David Tuvison. So I feel blessed to be up at the podium today. So I do have some disclosures. I do receive research funding and serve on the scientific advisory board for Immunovia and from ClearNote Health and Siglera. And I will be talking about several studies as part of a multi-center study, but will not be making any recommendations from them. I also want to disclose I truly do hate pancreatic cancer. Nothing will make me happier if I get out of a job with the. So Anirban set it up very nicely that we can't dream the general population for targets for those of us that are working with the hereditary patients. Yes, I think a stage shift in the short term, as he talked about, finding it at a more localized stage is a good goal. No for cystic lesions, and my colleague, Dr. Lennon, will be discussing that with you here shortly. I think we also have to take into account the challenges of pancreatic surgery, which is the end result. Be aware of our utilization of healthcare resources. We all know that's a problem. It's a growing problem in the US as well. And not only just for in general healthcare resource, but the financial and emotional stress that a patient undergoes when they're in an active surveillance program. Remember, they've all lived with seeing their loved ones typically die of this disease. And Anirban nicely highlighted the groups of patients that are at risk, and I'm just going to be focusing now on that 10% with a hereditary predisposition. So it was really back in 2007, and we started discussing this in 2005 as part of one of the inherited diseases of the pancreas symposiums held in Chicago. If you notice, it was called Advances in Counseling and Surveillance. We took away the term guidelines because guidelines takes data, and we really had no data back then. And several of the people at the conference today helped write these guidelines. And we sort of came up with the statement that there's no rationale to investigate early detection strategies in the general population at present, owing to the relatively low incidence of pancreas cancer, the inaccessible location of the pancreas in the retroperitoneum, the lack of diagnostic tumor markers, and the unavailability of any studies demonstrating survival benefits for such screening. But we sat in the room and we discussed, and we said, guess what? We want people that are at increased risk. We, at that time, suggested a 10-fold increased risk. The lifetime risk for pancreas cancer was about 1.2%. It's gotten up now to about 1.7%. And we came up with those mutation carriers that Anirban flashed across. And as you can see, it's not even that complete of a list, because this was back in 2007. We've added PALB2, Lynch genes, ATM to this list. And in general, I'm not going to spend too much on this. All these conditions are felt to predispose your increased risk enough to warrant it. But we were focusing initially on people who had a family history for these more lower to moderate risk genes, with the thought that that could enrich a little bit more to get them at a higher threshold. Also notice that there's this condition called familial pancreatic cancer, which is defined as having 2 or more family members with pancreas cancer, no known hereditary mutation, and the person who's the candidate for surveillance is directly related to a case of pancreatic cancer. So through the years, there's been lots of surveillance recommendations or guidelines, starting then with the CAPS initially, AGA, ACG, CAPS again revised, ASGE, which brought a lot of contention. And then almost on an annual basis, the NCCN makes recommendations as well. And all of these emphasize the importance of trying to get these patients followed in Pancreatic Cancer Center of Excellence, where they're tracking outcomes. And I think you'll see through the talk, that's one message, the importance of collaborating to beat this disease. Just as importantly, they're all based on low quality to very low quality of evidence. We have to realize there isn't great data. There's some differences, and I'll show you that in a moment, on who's surveillance candidates with them. But most importantly, they all recommend annual imaging. We want to find this cancer when it's small, localized to the pancreas, ideally by EUS or MRI. We try to avoid CT scans because as you do more and more radiation exposure with CT scans, you'll actually increase that individual's risk for cancer. And this is just a nice slide that I got by Dr. Lucas, highlighting the differences in the guidelines. The biggest one to note is that in 2022, the ASGE recommended all BRCA1, BRCA2, and PALB2 carriers be considered, even in the absence of family history, candidates for surveillance, starting at the age of 50 or 10 years younger than the youngest case. It was really a poorly written guidelines. The NCCN subsequently reviewed it and only made recommendations for BRCA2 and ATM. And they got rid of the BRCA1 and PALB2 because they did not reach a 5% lifetime prevalence rate. The other thing to notice with the NCCN now in the newest guidelines, they don't make recommendations for familial pancreatic cancer, but they do mention refer to other guidelines. Now, it wasn't until 2018 when Mimi Canto actually showed some improvement in 5-year survival rates. I realize could always be the issues of lead time bias, but she looked at 354 patients in the CAPS-4 study, which was just at Johns Hopkins with annual imaging. And what she found was a cumulative incidence of invasive cancer of 3.4%, which was only 12 of these individuals. And she calculated a progression rate of either getting cancer of about 0.8%, high-grade dysplasia 0.8%, which was about 1.6% per year. And importantly, 9 of the 10 PDACs were resectable, and 3-year survival rates were 90%. And of course, if you had high-grade dysplasia, you actually had excellent outcomes. And people still subsequently, many of them still died of pancreas cancer. We followed this up with the CAPS-5 study, which I participated in with several of the people in the audience here as well. And what we found of our study with, again, annual surveillance of now 1,461 high-risk individuals followed up to 6 years. At the end of that 6-year period of time, we only had 10 PDACs and 3 high-grade dysplasias. Now, it's important to note, though, that over 75% of those were at a stage 1 or less point. So our approach of doing annual surveillance did lead to better 5-year survival rates, but you really can't comment on whether more people were cured. And more importantly, did this strategy actually protect them from dying of pancreas cancer? So there's another limitation that we get with these, and that was seen with over 20% in this study, and it's what we call an interval cancer. When you have an advanced cancer that's found at the time of your next surveillance or prior to your surveillance. And this was a nice meta-analysis by Dr. Choda and James Farrell, and it shows that about half of these patients actually, when in the literature, are found to be beyond our goal of stage 1. And if you incorporate T2 and T3 in it, you get it close to 50%, which I still think is reasonable node negative disease. But it shows you that despite going annually, we still have a lot of limitations of finding it early. Now, why are we having so low rates? And in part, it's probably because a lot of our data is older data, and we are seeing the tip of the iceberg with these hereditary families. Now that next generation sequencing is so easy to do panel testing, we're finding more and more cases that don't fit the classic phenotype of a BRCA2 family or others. And I'm going to illustrate this by looking at the FPC data that Hopkins has presented. This is in 2022. And if you compare that then to 2010, and in particular look overall, there's been a significant decline, from almost 7-fold in 2010 for all comers of members of FPC, remember, directly related, 2 or more cases, down to a little less than 5-fold. And this was quite striking when you had 3 or more first-degree relatives, where you went from 17-fold down to 10-fold. And I think there's several other instances as well. So some of the summary, some clinical issues then are we have to really ask ourselves with interval cancers, are we achieving our goal of leading to more cures? It's obvious that 1,461 patients, up to 6 years of follow-up, 13 events, that we're probably overusing pancreatic imaging. And there really is just a limited number of PDAC cases, and that suggests the importance of consortiums so that we can track these and get more events. And I think we have to be honest, the risk is probably lower than expected. If you went with Mimi Cantos at 1.6%, we should be having a lot more cancers in our CAPS-5 study, and we did not. And I think just as important, when you look at data, we may be starting a little bit too early on surveillance when we're going 10 years younger or the age of 50. When you take all comers, for the most part, it's only a couple years younger when you have a pathogenic variant as compared to the sporadic cases. And again, this is an emotional stress, so it's hard to tell someone, don't start it when they've dealt with all these things. They're in guidelines, but I think you have to be honest with where we're at with risk, benefits, and limitations of surveillance. So how do we overcome these challenges? I think it really is through collaboration. I showed you, data of that with the CAPS-5 study that we had here. There's also the PROCEED Consortium, which consists of now 64 sites internationally, the EDRN that Dr. Matra referred to. We have the Pancreatic Cancer Detection Consortium, and the CPCRC, which was previously known as the CPDPC. So I really do think we need to rethink what we are doing. And by that, it's applying a lot of the same processes that we're doing with treating cancer and pancreatic cancer, target who's really high risk in the high risk group and who's low risk in the high risk groups. So enrichment again, but we need to enrich more. And for those that are at lower risk in particular, like less expensive and invasive surveillance strategies are likely warranted. And so with that, I'm going to show you now just a couple of examples of how with the PROCEED Consortium, we're starting to address that. And the first one is, this is again from that figure that I developed with Lynette Smith, where we look at either strategies of saving with blood-based biomarkers, images with strategy 1, and you can see the performance in that case requires a high sensitivity. It's usually shooting for 95%. With even a specificity of 50, you'll save 50% of the images and only miss 5% of cancers. Obviously, if your sensitivity was higher, 98%, you would be missing just 2%. Strategy 2 is catching those interval cancers at the 6-month point, and you just want to, for that test, you want a high specificity because you don't want to be repeating imaging every 6 months on these individuals. So how do we apply these? Well, I think, again, this is a collaboration with PROCEED with Immunovia that was just published in Gastroenterology. Additional sites also joined. And what they did was they used their Immunovia 2 panel up there at the top with a 5-marker panel, one of which it was CA19-9. Their preliminary data showed an 85% sensitivity as compared to CA19-9 alone. It was 65%, and really this study was set up in a blinded manner with the goal of proving that we could do a 65% sensitivity and greater than 90% specificity. And what I want to highlight here is what was really one of the few cases of biomarker case control studies is they included patients with hereditary predisposition, either cases that had BRCA2 mutations for pancreatic cancer, or those that were undergoing surveillance and followed for a couple of years so they could serve as controls. And when you looked at the data of all comers, their sensitivity was 78% with the panel, 93% specificity, and just as important, in our intended use population with the familial and genetic cases, the sensitivity was maintained compared to overall. And interestingly enough, the specificity was a little bit higher even in the hereditary case, but to me, it was at least maintained. The other one I want to highlight now, so that was still case control. Clearnone is now doing a collaboration with over 20 PROCEED sites in a prospective manner with their biomarker assay, Avantic. And really, this is a biomarker assay that's dependent upon 5-hydroxymethylene methylcytosine. So looking at the epigenetic effects, with also measuring CNV features and fragment size. They're all put together in an algorithm, and they come out with a call. And they had some preliminary data that they published in CGH in 2023 that showed for early stage sensitivity about 68% and about a 97% specificity. And so this is still early in the course. It's been about a year. We really didn't have any longitudinal studies, but what you could see is that we did have a total of 12 positive tests, 5 of which were normal on the corresponding imaging, 5 that had sort of these non-specific pancreatic findings that we're starting to slowly explore as we expand it. And then most importantly, there were 3 patients in the study that had solid lesions, including one that unfortunately had an advanced pancreatic ductal adenocarcinoma detected. And then the other 2 solid lesions are actually pancreatic neuroendocrine tumors, but those 2 PNETs were not detected. So to summarize these findings, it does suggest a high specificity for their test. Out of the 12 positives, 1 was an advanced PDAC, but we don't know whether these are false positives yet, because we need at least another year's worth of follow-up, and ideally 2 years, as Anirban showed you in his slides, with pre-diagnostic samples and signals. I think this is going to occur with these blood biomarkers. Our imaging may not pick them up. I think if you look at the positive predictive value of 29% and MPV of 99.55%, and that's really using an assumption of a 1% disease prevalence. So it clearly does warrant standard of more study. And so with that, I'll end and just thank. The only reason why I personally can do these studies is because of the vast collaborators I have at my institution and continued biomarker work with my outside collaborators. So thank you for your attention.
Great talk. So it's my pleasure to introduce our next speaker, Dr. Ann Lennon, who's going to be talking about the management of IPMNs.
Thank you very much. It's a pleasure to be here. And I've been asked to talk about identifying IPMNs with high-grade dysplasia challenges and opportunities. So we heard from Dr. Matra, our aim is to detect what IPMNs and pancreatic cysts offer the opportunity to screen for pancreatic cancer. And they probably account for 10 to 15% of pancreatic cancers. Unlike PANNs, they are easy to detect, but there's a number of challenges with them. The first is that not all pancreatic cysts are IPMNs, and many are in fact benign cysts such as serous cysts. And if you look at large surgical series, around 15 to 20% of surgically resected cysts are in fact turn out to be entirely benign. The second problem is that not all IPMNs progress to pancreatic cancer. In fact, a tiny number do. And if you again look at large surgical series, in a recent one, looking from 4 large major centers in the US, found that 73% of branch duct IPMNs which underwent resection did not have high-grade dysplasia or early pancreatic cancer. And finally, if we look back 10 years ago, we were detecting pancreatic cysts in just over 2% of CTs that we performed. Nowadays, that number has increased tenfold. And so this is a huge problem for us. So pancreatic cysts, our first is, so if we want to use pancreatic cysts for screening, there are 3 simple questions that we need to answer. First and foremost, we need to determine, identify, differentiate IPMNs and MCNs from other types of cysts. Secondly, if this is an IPMN or MCN, we need to determine, is there high-grade dysplasia or early cancer in it now, in which case we want to refer the patient for surgery, or is it safe to watch? And I think the gold standard, which we would love to do, is if there's no cancer in it now, can we identify those individuals who will go on to get cancer? So where are we in November 2025? And the answer is, I think we have many challenges. So the tools that we have are blunt instruments and are imperfect. So these are the most recent Kyoto guidelines. And you can see that they recommend that we use classic characteristics to determine what type of cyst are we dealing with. For example, gender and location of the cyst is used to identify MCNs, which primarily occur in women and are located in the body and tail. And we use the presence of communication between the cyst and the main pancreatic duct to differentiate a branch duct IPMN from other types of cysts, such as serous cysts. However, if you look at the data, and again, this is what we're currently using in 2025, these are blunt instruments and are far from perfect. So this is a large surgical series in over 850 patients who underwent surgical resection. And what you can see is less than 50% of patients that ultimately were found to be IPMNs in their preoperative report actually had communication reported on their imaging report, while 17% of cysts that ultimately turned out to be serous cysts were reported to have communication. So what other tests do we have? Well, CEA was described over 20 years ago, but it again is imperfect with a sensitivity of less than 60% for identifying IPMNs. We have cyst fluid glucose, which is very promising with sensitivity of 93% and specificity of 76% for identifying IPMNs, and in head-to-head studies is superior to CEA. Finally, we have cytology, which is something as endosonographers almost all of us send, but again, it is imperfect. Its specificity is greater than 90% for identifying cyst type and high-grade dysplasia, but the sensitivity is only 54% for telling us exactly what type of cyst we have, and 65% for identifying high-grade dysplasia or cancer. So how can we improve this? So one way of doing this that's been approached is using through the needle microbiopsy forceps. And for those of you in the audience who are not endosonographers, this is where we put a tiny needle into the cyst. And the concept is, can you grab a larger piece of the tissue and therefore help our pathologists increase the sensitivity? So how good is it? So in a large systematic review and meta-analysis that looked at over 600 patients in 11 studies, the pool sensitivity and specificity for identifying IPMNs and MCNs from other types of cysts, that's the first thing that we need to do if we want to screen for pancreatic cancer, was 80%. Now, if you look at this data in a little bit more detail, what you'll find is that 9 of the 11 studies were in fact retrospective. And if you look at the largest prospective study, which was in 101 patients, you can see it was great on one side that it made a 12% difference in management. However, 10 of the 101 patients had an adverse event, of which 4 were severe, and there included 1 death. So what else can we use to answer that question? How do we identify an IPMN or MCN? How do we identify high-grade dysplasia? So we have needle-based confocal endomicroscopy. Again, for those of you in the audience who are not endosonographers, that's where we put a tiny needle into the cyst with a probe. And that probe provides real-time, high-resolution visualization of the epithelium and stroma, effectively offering in vivo histopathological analysis of the cyst. And this is what it looks like. So in IPMNs, you've got papillary finger-like projections, while in serous cysts, you've got these branching capillaries with densely packed red blood cells. So how good is it at identifying IPMNs and MCNs? And again, in a large systematic review of 9 studies and over 500 patients, NCLE has 86% sensitivity and 83% specificity for identifying IPMNs and MCNs collectively. What about telling us exactly what type of cyst we have? So you can see here the accuracy for serous cysts was 98%. The accuracy for cystic pancreatic neuroendocrine tumors, solid pseudopapillary tumors, and pseudocysts was 96%, while the accuracy for IPMNs was 86% and MCNs was 84%. So what about the second question? Can it detect high-grade dysplasia? So Sam Krishna has led a huge amount of the work in this area. And in a study where there were 60 patients with surgical pathology, he took experts from around the world, and they were able to identify the presence of high-grade dysplasia pancreatic cancer with 58% sensitivity and 59% specificity. Now, one of the big challenges of NCLE is that there's a huge amount of imaging data, and it's very time consuming and labor intensive to actually look at this data. And so Sam, who's very brilliant, came up with the idea of maybe you could use AI to do this. And so what he did was he developed an AI model which was able to analyze all of this data and make it much shorter. But in addition, he asked the question, how good is AI compared to a human? And these are the results. So again, in a preliminary study using AI, you can see that the AI had a significantly higher sensitivity and fairly similar specificity for identifying high-grade dysplasia. Now, again, if you look at these papers, what you'll see is that these cysts are large, typically over 3 centimeters. And as all of us know, the vast majority of IPMNs and pancreatic cysts that we deal with are much, much smaller. So what else do we have? Well, molecular markers can be evaluated in as little as 200 microliters of fluid and offer a way to evaluate much smaller cysts. In 2023, Atur Singhi led a multi-center study which was published in Gastroenterology using a 22-gene DNA-based next-generation sequencing panel. It was evaluating just under 2,000 patients from 31 centers, and what it showed was that it was able to identify mucinous cysts with 90% sensitivity and 100% specificity, and high-grade dysplasia or early cancer with 89% sensitivity and 98% specificity. Now, one of the wonderful things about Atur is he always wants to push the boundaries and rapidly bring new discoveries into clinical practice. So fast forward just 2 years. And where are we? Well, he's gone up to evaluating it. It's been evaluating almost 12,000 patients from 50 centers across the country. And he's gone from a 22-panel DNA marker to 74-panel DNA and RNA marker, which includes hotspot DNA alterations, indels, SNPs, copy number alterations, gene fusions, and gene expression changes. And this, as we improve, how does that impact our ability to detect pancreatic cysts and high-grade dysplasia? And here's the data. So you can see here that our ability to identify mucinous cysts improves, the sensitivity is improved from 88 to 95%, while our ability to detect high-grade dysplasia has increased again by 7%, going from 80 to 87%. How does this compare to the features that we currently use in 2025 for detecting high-grade dysplasia, i.e. worrisome features, malignant cytology, and high-risk stigmata? And as you can see here, the accuracy is better at 92%. The field has also continued to rapidly move forward, and I just want to highlight a few of these areas. So we've known for many years that serous cysts have got VHL mutations. That's how we identify them. But again, the field has moved forward, and now we're seeing additional mutations present, including TP53, TERT, IDH1, and IDH2 have been found and are often associated with larger cysts. So hopefully, as we move forward, that number of 15 to 20% of resections, which are in benign cysts, will be able to be a thing of the past. So Dr. Singhi and colleagues performed whole transcriptome sequencing, essentially looking at over 80,000 express sequencing and correlating them with diagnostic pathology for over 1,000 pancreatic specimens. And again, this has led to us moving the field forward. And again, I'm going to highlight just a small number of the findings. One of the really exciting findings we saw was that we know that MCNs are very challenging to distinguish preoperatively from a single IPMN. And through RNA analysis, Dr. Singhi and colleagues identified FOXL2, which was found to be highly expressed in cyst fluid from MCNs. And in a study presented at this meeting, it was reported to have 98% sensitivity and 100% specificity for MCNs. Another new finding that the team reported was that they evaluated immune infiltration in pancreatic cyst fluid and found changes in the immune environment associated with IPM grade. So if you look on the left-hand side, you can see the B cell panel. And if you look at, you can see that the number of B cells present in low-grade dysplasia is high and then decreases significantly as we move towards either high-grade dysplasia or cancer. And I think this is a very interesting finding, and as we look at vaccines for interception. So we've made huge progress, but as a clinician, I think one of the problems that we face is a huge amount of data and the rapid advances in data that we're seeing. And it's becoming increasingly complex. So at the moment, we have to look at clinical features. We heard about new onset diabetes early in the meeting, family history, germline mutation, surgical morbidity, life expectancy, CT, MRI, EUS findings, change in cyst over time, CEA, glucose cytology, NCLE, and currently 98 molecular marker, which are likely to go to 120 or 140 in the next 6 to 9 months. So how do we deal with this in tertiary and quaternary centers, let alone in community centers? So AI models are uniquely equipped to deal with a huge amount of diverse and complex features. And I do not see them replacing physicians, but they have the potential, I think, to aid physicians in making informed decisions. And so I'd like to share this paper with you as I think it gives an idea of the concept of what this could look like in the future. So multiple clinical, imaging, and molecular features are evaluated. The model generates a probability of what type of cyst we're dealing with and the recommended management. And in this example, it has a 76% probability that this is a benign serous cyst. In blue, you can see the features associated with the probability, with the highest weight being a VHL mutation in the absence of a GNAS or high-risk mutations, followed by the absence of a solid component or a mural nodule. There was a 15% probability that this could be an IPMN which required surgical resection. And in red, you can see the features associated with that probability, which was the presence of a dilated duct or large cyst size. Finally, you can move from the individual patient to the model level and evaluate what is the performance of the model based on all resected cases. And you can see here that all the cases that had an 80% probability of discharge and a 20% probability of surgery were correctly classified by the model, giving you confidence that the diagnosis of a serous cyst is likely correct. In the last few minutes, I would like to briefly highlight some of the work that's been done on interception. That is the concept of intervening and preventing the progression of IPMNs. So Peter Allen is leading the prevention and progression to pancreatic cancer trial. This is a randomized double-blind placebo-controlled phase 2 trial where 100 patients were randomized to placebo or Sulindac, and we look forward to hopefully seeing the results of this study in 2026. Mutant KRAS is a frequent alteration in IPMNs and PANNs. We believe that we have a 10-year, hopefully, period where we can intervene, and it offers a potential as an immune-based interception strategy. I want to thank Dr. Naya Zaidi for sharing her slides. So Dr. Zaidi has led the first in-human mutant KRAS vaccine in high-risk cohorts. This is a single-arm, open-label, phase 1 study of a pooled synthetic long peptide vaccine targeting up to 6 mutant KRAS subtypes. And in this study, patients with a pancreatic cyst and either a family history of pancreatic adenocarcinoma or a germline genetic mutation were enrolled. The vaccine was given on weeks 1, 3, 5, and 13, and peripheral blood was collected at baseline and at weeks 5, 13, and 17 for analysis of immunogenicity using interferon gamma ELISA. The primary endpoint of this first in-human study was safety and mutant KRAS specific T-cell response. So this is only published in abstract form, but again, Dr. Zaidi kindly shared the results today for me to share with you. So they've completed enrollment of 20 patients, and what you can see is 90% of those were immune responders, reaching the predetermined threshold of greater than or equal to 2.5-fold increase in the average mutant KRAS specific response. 80% of the patients responded to all 6 mutant KRAS antigens included in the vaccine. While on the panel on the left, you can see the dynamic changes in the immune response over time. The team performed immune phenotyping of mutant KRAS specific T cells post-vaccination. And on the left, you can see the highly active CD4 and CD8 cells, and they were able to co-express more than one cytokine. On the right, you can see the majority of T cells were effector and central memory phenotypes, suggesting a long-term response. And finally, you can see some of the patients have been followed for 1 or up to 2 years, and you can see that the mutant KRAS-specific T cells were detectable up to 2 years post-vaccination. Now, of course, all of these results are in the blood, and one of the key questions that we want to know is what's actually happening in the cyst. So to answer that question, the team developed a second study, enrolling patients with IPMNs undergoing surgical resection. And as you can see here, the vaccine was given at weeks 1 and 2 prior to surgery, and blood was collected peripherally before surgery as well as afterwards. Now, they've recruited 4 of 10 patients for this study, and again, it's still enrolling. So in these preliminary findings, they found the same findings of the immune response in the peripheral blood, shown on the left, and in the surgical specimens showing inflammation and infiltration of lymphocytes. So we started with the challenges that we have, and that in November 2025, we have blunt and imperfect tools to firstly identify IPMNs and then identify those with high-grade dysplasia or early cancer. But I have highlighted a small number of the incredibly exciting advances that are happening, and I hope that our approach to the diagnosis and management of patients with IPMNs and pancreatic cysts will be very different in 3 to 5 years' time. I'd specifically like to thank Dr. Atir Singh and Neha Zaidi for sharing their results and slides with us today. And thank you so much for your time.
Thank you for the wonderful talk. Now I'm pleased to introduce the last speaker in this session. It's Dr. Majenda from Mayo Clinic. He's going to talk about the liquid biopsy and the early detection of PDAC, please.
Thank you, and I would really like to thank the organizers of APA for this honor to speak at this session following speakers who have all made seminal contributions to the field of early detection of pancreatic cancer. So here are my disclosures. Probably most relevant to the talk is Mayo Clinic has a IP development agreement with Exact Sciences, on which I'm listed as an inventor, and some of the work I'll be sharing reflects work that has been done in collaboration with them. So I'll start by spending a couple of minutes summarizing some of the key concepts that you've already heard in this session. Pancreatic cancer presents both a challenge and an opportunity, and the biggest challenge is that nearly half of the patients are diagnosed at a stage when cure is impossible and largely ineffective. And the window of opportunity you heard Dr. Maitra describe lies in the early detection. So if you look at 5-year survival rates, the 5-year survival is significantly higher, close to 40 to 50%, when the disease is diagnosed at an early localized stage. I'm a pancreatologist. I spend a fair bit of time in the clinic, and this is the usual presentation. It's a older male with abdominal pain, weight loss. We do a CT scan. We find not only a large tumor in the head of the pancreas, circled in red, encasing blood vessels, but oftentimes disease that's spread outside the pancreas. And the prognosis here is terrible. We are measuring survival in the order of weeks and maybe months. And there, as you heard, there's no population screening for this disease, and it's largely because of the risk of overdiagnosis and overtreatment. It's not a very common cancer, so despite it being a very lethal cancer, there's really no good evidence base to support screening the entire population. So this is the current paradigm. You try to enrich the average risk population for risk factors, delineate a high-risk population, whether that be NOD, cystic lesions, family history, germline risk, and then screen that group. So that's really your intended use population for for any diagnostic test that is going to be detecting this disease early. But early detection is impactful, and you heard some of that information in the previous speakers' presentations. Here's an example of somebody with a CDKN2A germline mutation undergoing surveillance with MRIs, and it even takes a trained radiologist a lot of attention to find these really small early tumors. So I can point to where there's a small ductal adenocarcinoma, sub-centimeter ductal adenocarcinoma, identified in this patient, and obviously the outcomes are significantly better and the treatment options are more. So the AGA, the ASGE, the NCCN, they have all reacted to these findings to indicate that there's really expert consensus and support for doing clinical pancreatic cancer screening in high-risk individuals. And that's really the reflection of, as you heard from Dr. Brand, 20 years of persistent work by many members who are even in this room to drive us to this stage. So it's fair to say that pancreatic cancer screening in high-risk individuals results in a stage shift. 70% might be optimistic, 50% may be the lower bound, but it's definitely more early stage detection compared to sporadic pancreatic cancer, where the number is probably in the 10 to 20% range. And there is emerging evidence now that despite the limitations of lead time, there's data suggesting that this increases 5-year survival and overall survival. So as the field advances and we are getting better at identifying people we should be offering screening to, what is the target of screening? Like any other cancer, pancreatic cancer progresses through stages of low-grade and high-grade dysplasia before progressing to cancer. And both the solid and the cystic precursors can be classified broadly into these 2 grades of dysplasia. So we all want to detect early stage cancer, but it would also be wonderful to be able to accurately detect high-grade dysplasia. That's an advanced precursor that's about to turn into cancer. You saw pathology images of what that looks like. And Dr. Meitz mentioned that that's really what we are driving towards and trying to get close to that. So a biomarker that accurately detects high-grade dysplasia and asymptomatic early-stage cancer is what the field of liquid biopsy and cancer diagnostics is driving towards. Before I go into liquid biopsy and the different tests that are under development, I really want to draw your attention to this paper that was published more than 20 years ago now, that continues to be the framework that we need to think for biomarker development. And as you see, these are phases of biomarker development. So phase 1 is early exploratory preclinical studies. This is where most of the discovery happens, oftentimes in human tissue. And then a phase 2 study would be to do a case control study, which is a clinical assay that is then validated in a case control setting, which then translates into a phase 3 study, which deals with pre-diagnostic samples, where the goal is to see if the biomarker can detect the disease before it becomes clinically overt. And once you get to that stage, and that's a biomarker that you want to test performance characteristics in a prospective screening study, and then finally see if it affects population health. So these are the PEPE phases of biomarker development, which I think still continue to serve as a framework for a lot of the work being done in this field. And there are some key considerations when looking at these blood-based liquid biopsy studies. I think it's important to pay attention to how these markers were identified, whether there was tissue validation to show that there's concordance between these markers in pancreatic cancer tissue and in blood, which particular PEPE phase does the study belong to, and how candidate markers were selected. Are all important considerations. Another thing that Dr. Brandt mentioned towards the later part of his talk, I think is very relevant for the field to recognize is the eligibility criteria for controls in these studies. Most of the studies use pancreatic cancer, ductal adenocarcinoma, biopsy-confirmed cases, but the controls can be quite variable, ranging from healthy individuals to those with pancreatic disease, with and without representation of the high-risk individual populations. That's really the intended use population for the screening tests. And then it's important to pay attention to whether there was independent validation, whether there was a locked algorithm, or is this something that's still under development. So these are some overarching topics that I think warrant attention when critically reviewing the published evidence in this field. For those who are not familiar with liquid biopsy, very broadly speaking, liquid biopsy is the technology to assay cancer-related material from a blood sample, could be nucleic acids, could be proteins, could be other things. And what I'm going to present in the next 8 to 9 minutes is by no means a comprehensive overview of everything that's available. But hopefully I'll give you an overarching understanding of where the field is, what the unmet needs are, and what the direction is that we need to follow. So I'll start with CA19-9. This is a tumor marker that we all are familiar using in our clinical practice. It's the cornerstone of monitoring treatment response in patients with pancreatic cancer who are undergoing treatment and for prognostication. And the question that could have easily been asked is, can it detect disease before clinical diagnosis? So this is the work that Dr. Moitra presented in the first part of his talk. And this was a study that was done by Johannes Farman, Brian Wolpin, and others, published in Gastroenterology several years ago, looking at what happens to CA19-9 in the pre-diagnostic phase of pancreatic cancer. Large study, 175 cases. As you can see, samples collected up to 1 year, 1 to 2 years, or 2 to 5 years before the clinical diagnosis of pancreatic cancer, and matched to cancer-free controls from the PLCO cohort. And you see the window of opportunity labeled there in light pink, showing that for a phase of time before the clinical diagnosis, these biomarker levels go up. But it's important to recognize that if you look to the graph on your right, where you're looking for clinically relevant sensitivities that Dr. Brand mentioned in his talk, the marker really does not get to those clinically relevant levels of sensitivity till maybe 3 months before diagnosis. And if you're an optimist, you'd say 6 months before diagnosis. So this highlights that while there is a window of opportunity, the performance characteristics of the test that is required to do early detection needs to be different. And so that drives to the need to develop biomarkers that really complement CA19-9 for detecting early stage pancreatic cancer with sufficient time so that we can intercept the disease and change the outcomes. Early efforts looking at alternative protein biomarkers. This is work done by Ken Zarrett at UPenn, who continues to be a collaborator till date as part of the PCDC consortium, looked at thrombospondin-2, a very promising biomarker in phase 2 studies. Again, looking at comparing cases versus healthy controls, and showed that you can actually add proteins to CA19-9 and create a panel that augments the diagnostic capabilities of CA19-9. And you see in a phase 2 study an AUC of 0.96, very compelling sensitivities and specificities. And then you move this into the next phase. You move this into a phase 3 study, which is what Ken did. This was done in collaboration with Gloria Peterson at Mayo Clinic. And the results were not that exciting. And you'll see that as you move further and further away from the date of diagnosis, if you go to 3 years before cancer diagnosis, the AUCs are all in the 0.5 to 0.6 range. And even once you get close to the diagnosis within a year of diagnosis, you're not seeing the same degree of discrimination as you would expect to see in a phase 2 case control study. So I use this as these two examples to highlight the fact that phase 2 performance is very good. It's good to establish phase 2 performance, but the real utility of a test has to be demonstrated in a phase 3 study. Now, moving on from proteins, the concept of multi-target assays for cancer detection is very familiar to most people in the field now. This is looking at, can we add other complementary types of candidate markers to augment the function of proteins. You just saw a fantastic work done by Athur Singhi, looking at a wide spectrum of molecular signatures in cyst fluid. So some similar studies have been performed in blood as well. Our group at Mayo Clinic, this is going back several years now, led some of the work to do discovery on pancreatic cancer tumor tissue. And we were looking for differentially methylated regions that distinguish between cancer tissue and normal pancreas tissue. Not only cancer and normal, but we were also interested in seeing if there are specific differentially methylated regions that differentiate low-grade precursors from high-grade precursors. And we did find several of these markers in tissue that were highly discriminatory, with individual AUCs approximating 1. So we then took the combined analysis of our RBS libraries and we put through stringent marker selection criteria, specifically looking for performance characteristics that would allow them to function as blood-based biomarkers. And we took 13 of these methylated DNA markers into a phase 2 case control study. comparing treatment-naive ductal adenocarcinoma patients with healthy controls. And we showed that, yes, indeed, if you combine the methylated panel with CA19-9, they both tend to have similar performance when viewed independently, but put together, there is some complementarity. So again, driving at what can we do to enhance CA19-9, which seems to be a fairly good anchor biomarker for most of these panels. And this panel achieved a sensitivity and specificity upwards of 90% at the time. But I also want to draw the attention to the fact that as you look at this bar diagram of sensitivity across stage, you can see that stage dependent sensitivity, there's a drop in sensitivity as we go to earlier stages, and the confidence intervals get wider. And that's really the area we need to focus in as a field, is how can we improve the confidence around sensitivity of some of these tests in early stages of the disease. There's work done by Ajay Goel's group at City of Hope looking at RNA markers, very promising early data, looking at circular RNAs that are overexpressed in PDAC, again, derived from very robust tissue studies and then translated into a blood-based panel, again, showing that if you combine it with CA19-9, it really augments the performance of CA19-9. And while there's all this work going on in the domain of single organ cancer detection, another field that has emerged, and you heard Dr. Lennon speak, she has done some seminal work in the domain of multi-cancer early detection. And so these tests are coming through. There are a lot of prospective cohort studies that have been done. The challenge is that pancreatic cancer is not common, so it's often underrepresented in these cohort studies. It's very challenging, hence, to understand how these tests perform for that particular cancer type. But this is a question we get in clinic all the time, is we have these multi-cancer early detection tests. Can I use that as a screening tool for pancreatic cancer? Why do I need a single organ test if I can detect all these cancers in one test? I think the important things to recognize is that these tests were developed with a focus on general population screening and were hence trained at a very high specificity threshold to mitigate the risk of false positives. They were not trained on individuals at high risk for pancreatic cancer. And in this population, we are trying to maximize PPV, so maybe a lower specificity would be more tolerable. A big unanswered question is, what's the false positive rate in these intended use populations of high-risk individuals? And so we aim to do this study and shared some results at Digestive Disease Week earlier this year. We wanted to retrain the algorithm of an existing MSED assay to see if we can really optimize it for sensitivity around early stage pancreatic cancer and measure the false positive rate in disease controls, such as those with cysts and pancreatitis and familial and germline risk. What we found is that, yes, indeed, if you tailored the test down to markers that are most informative for pancreatic cancer, then the combination of these methylated markers and CA19-9 was able to identify the vast majority of pancreatic cancer cases, and even in the earliest stage cases, sensitivity of about 73%. What was really informative for us is we looked at 80 controls, both healthy controls and disease controls, and saw that the specificity of the test remained high despite this wide range of controls. So I'm closing in towards the end of my talk, and I'd like to share a few minutes talking about the relevance of these tailored phase 2 studies. So you've heard me talk about phase 2 case control studies, and a lot of the pancreatic cancer biomarkers that progress through these phase 2 studies are often not rigorously tested in high-risk individuals. And this is not because we don't want to do it. It's largely because while there are many high-risk controls, high-risk cases are not very common. And high-risk cases comprise only 10 to 15% of all PDAC. So if you say that all the cases in a case control study need to be pancreatic cancers in patients with a family history or in patients with germline risk, that really limits the sample size and the design of the study. So that's been a challenge for our field. And another question is, how convinced are we that the biomarker panels, as they go through development, can actually detect sporadic disease accurately, can also do so in high-risk individuals? So we have put the methylation markers that we have been working on through this test in tissue, showing that the markers discriminate germline mutated and family history positive cases, similar to what they do in sporadic cancers. This is a tissue study, and we are in the process of doing some similar work using blood samples. I want to draw your attention to a paper that is published online now, led by Dr. Brand and others, and supported by Immunovia for the test PancreaSure, which again is a combination of different biomarkers into one biomarker signature, which is starting to drive at this question of, can we actually include controls that have familial risk and genetic risk, a very important question that needs to be answered, and also really addressing the early stage pancreatic cancer. So this is an important publication for the field. And as you can see, we're looking at a specificity that's not 99%. And so that's something to pay attention to, is that a test that has a sensitivity in the 70s and a specificity in the low 90s may be something that we could utilize in the setting of high-risk individuals. Now, can we move beyond blood and closer to the tumor? There is some work going on with pancreatic juice biomarkers, and we recently published a paper looking at not only the juice biomarkers by themselves, but combining them with plasma CA19-9. So this idea of, can you combine a juice-based marker with a blood-based marker to further augment diagnostic performance? And another question I think is very relevant, tying back to the first speaker, is who do we screen? A lot of the patients who need to be screened are not getting screened, and only about 10 to 15% of all PDAC meet our current screening criteria. So there's work to be done on expanding the intended use population for these early detection tests. So I would like to summarize by saying that you've probably by now been convinced that there are blood-based biomarkers that can detect early-stage pancreatic cancer with reasonable accuracy in phase 2 studies. We need more tailored phase 2 studies targeting the intended use population, where case control studies include the familial and genetic risk patients on both sides of the equation. And large consortiums need to come together to do prospective phase 3 studies to look at pre-diagnostic performance and variability over time. I'll leave you with this question to think about as you have dinner tonight. What is the optimal performance of a blood-based test that will have an impact on the field? Are these going to be used by themselves, or are we going to combine it with other tests? And if we are going to combine it, how are we going to do that? With that, I would like to acknowledge our funding sources and this incredible team of talented individuals I get to work with at Mayo Clinic. And if you're sitting in the audience as a trainee with aspirations to do clinical and translational research work in pancreatic disease, which we all need more people to do that, here's a plug for the Mayo Medical Pancreatology Fellowship, which I have the honor of leading. So thank you all for your attention, and we would all be happy to take questions. Thanks.
In the interest of time, since we're running late, we can't take any questions. So please find the speakers if you have any burning questions after the session.
We'll get started in just one moment here. Water in here in a moment. Yes, we have a clicker up here. The green button up here. This one here is like a pointer, but I'm not sure it's working. It doesn't seem to be working all day. This is the big green button. Big green button. Big green button. Tell us. All right, I think in the interest of time, since I know we have a reception after this as well, if you want to come in and get your seats, we'll get started in a moment.
there's Dr. Saluja. Are we good?
Let's give a couple
Okay.
minutes for people to.
Okay, well, I just told him to come in,
Yeah.
so yeah. And we have our
So
notes.
how you want to introduce?
I could, do you want me to,
Whatever, whichever you will. Do you want to introduce, you know the fellows or maybe?
I don't know him, so maybe you should introduce him,
And you
but we have,
The first two.
I can introduce first two and then turn it over to you to introduce our keynote. Yeah. Think we're good? Yeah, yeah. Okay, we're gonna go ahead and get started with this evening's session. I'm gonna give you just a quick background on this session. We had for many years a woman in pancreas. I think it was more of a breakfast session at the APA. I think roughly 4 years ago, we decided that was maybe not broad enough, and we expanded this to an inclusion and equity session at the APA and have invited a keynote speaker in the evening each year. And this year we thought maybe that wasn't quite enough. We have some very good abstracts that get submitted to the APA on the topic of equity and inclusion, and we wanted to feature a couple of those abstracts. So the way we're set up for this year, which is new, is we have a couple invited abstract presenters, and then we'll have our keynote speaker. So with that, I will introduce our first speaker. This is Dr. Radmila Choate, excuse me, from the University of Kentucky, and she is presenting financial hardship in patients with chronic pancreatitis, insights from the All of Us program. So welcome.
Good evening, everyone. I would like to start today's presentation with a simple but an important question. What is the real cost of a person's illness? Is it just the number on the hospital bill, or is there something more to it? So in the next 10 minutes, we will look beyond the dollar amount to discuss the broader cost of chronic diseases, and specifically chronic pancreatitis, and their consequences on patients' lives and overall well-being. Let's begin with some numbers to set the stage. Between 2007 and 2012, the direct medical costs of ambulatory and inpatient treatment for chronic pancreatitis averaged approximately $150 million annually. Hospitalization costs have nearly tripled between 1997 and 2014. We know that the costs of diagnostics and treatment, such as CT scans, ERCP procedures, PERT therapy, are very high. And this is just part of the picture. In 2022, approximately 43% of adults in the United States were inadequately insured. In addition to medical expenses, patients face indirect costs like missed work days and wages, transportation to appointments, psychological stress, and a major decline in their quality of life. So what is financial toxicity? The term financial toxicity first appeared in oncology literature. It refers to the harmful financial burden that comes with the cost of treatment, analogous to physical toxicities of cancer treatment. Cancer researchers developed a 3-domain model to understand this concept. First is material conditions, such as increased out-of-pocket expenses and loss of income due to illness. Second is psychological distress, the anxiety and stress of trying to balance household budgets during treatment. And the third is coping behaviors, the trade-offs that patients make like skipping medications or delaying care to manage costs. We call it cost-related non-adherence to treatment. This model provides a framework that can be applied beyond cancer to other chronic conditions, such as chronic pancreatitis. To measure financial toxicity, the COST, Comprehensive Score for Financial Toxicity instrument, was developed and validated in cancer. Since then, it's been revalidated in other chronic conditions, such as diabetes. Within gastroenterology, a few studies have explored financial toxicity in IBD and Crohn's disease. However, no quantitative data yet exists for the diseases of the pancreas, which makes this an important area to explore. Our group recently conducted a review on financial toxicity in chronic pancreatitis published last year in Pancreas. We found that financial toxicity in chronic pancreatitis is multidimensional. It affects finances, emotional health, care decisions, and it is both under-recognized and under-measured. This gap prompted us to take the next step, to characterize financial hardship in chronic pancreatitis using large national level data. Building on that foundation, we conducted a study using data from NIH All of Us research program. Our goal was to characterize financial hardship in chronic pancreatitis, as well as compare it to other chronic conditions, such as congestive heart failure, COPD, and liver cirrhosis. The All of Us program offers rich real-world data through surveys and electronic health records. We used responses specifically from the Healthcare Access and Utilization Survey, which captures experiences related to affordability of care, delays due to cost or transportation, cost coping behaviors, and these variables allowed us to construct a cross-sectional profile of financial hardship in chronic pancreatitis. Our study included 1,063 adults with chronic pancreatitis with a median age of 57 years. Most were female, white, and non-Hispanic. Almost half reported low income, and about 1 in 4 had a high school education or less. Insurance coverage varied across participants, and rates of tobacco and alcohol use were high, which aligns with known epidemiologic patterns in chronic pancreatitis. Our findings were striking. About 20% of patients were unable to afford their prescriptions or dental care. 18% delayed care due to lack of transportation, and 14% delayed care due to cost. Moreover, more than 1 in 5 requested lower cost prescriptions. 17% delayed medications for cost reasons. And even more concerning, 13 to 14% reported skipping or reducing medications due to cost. And perhaps the most striking finding was that nearly half of the patients said that they were worried about paying their bills in the event of any illness or an accident. Here you see a spider plot comparing reasons for delay in getting care among chronic pancreatitis in purple versus other chronic conditions: congestive heart failure in red, COPD in blue, and liver cirrhosis in green. Each axis represents a specific reason for delayed care, such as cost, transportation, or appointment availability. The farther out the line extends, the higher the prevalence of that issue. As you can see, the purple line for chronic pancreatitis sits on the outermost edge across several dimensions, showing that chronic pancreatitis patients experience the highest rates of delayed care among all the compared groups. A similar pattern emerges when we look at cost coping behaviors. Again, the purple line for chronic pancreatitis extends furthest outward, showing that these patients often take less medications, seek alternative therapies, or request lower cost prescriptions compared to those with other conditions such as COPD, heart failure, or liver cirrhosis. These findings collectively paint a picture of significant financial strain, coping behaviors that may directly impact disease management and outcomes. And lastly, we saw a similar pattern when participants were asked whether they could afford certain treatment when they needed it. As you can see, the purple line representing chronic pancreatitis extends furthest outward in several categories, particularly prescription medications, emergency care, and mental health counseling. This pattern highlights that people living with this condition face some of the highest rates of unaffordability across multiple essential healthcare domains. In summary, our study demonstrates that financial toxicity in chronic pancreatitis is substantial. In many cases, it is greater than that seen in other chronic conditions. Financial hardship in chronic pancreatitis affects multiple domains of patient lives, influencing adherence as well as access to care and overall well-being. Building on these findings, I'll be leading a pilot study through the University of Kentucky Ascent Scholar Program. This will be a mixed methods, community-engaged project that combines two key components: a quantitative assessment using the validated cost instrument and qualitative insights from semi-structured patient interviews. By integrating these findings, our goal is to develop chronic pancreatitis-specific conceptual framework and ultimately a new patient-centered measure that reflects the financial challenges and experiences most meaningful to individuals living with this chronic condition. And finally, I would like to thank all the collaborators and contributors, as well as our funding sources. Most importantly, I'd like to acknowledge all of us participants whose contributions make this type of research possible. And last, I would like to thank APA organizers for the opportunity to share this important work.
Thank you. We'll take one or two questions if there are any. I do actually have one. That was very excellent. But I'm wondering in the All of Us data, is there enough information to be able to look at kind of complications of chronic pancreatitis like diabetes, exocrine insufficiency? Because I see a lot of your financial toxicity seems to be medication-based, right? And those are particularly expensive medications for diabetes and exocrine insufficiency.
Absolutely. All of Us research program is a very complex database. There are a lot of data points that are related to exacerbations and treatment types and medications. And this, as a matter of fact, is our next step to explore this further to determine whether any specific medications or any complications and treatment for such play the leading role in financial burden.
Thank you. I don't see any other questions, so thank you very much. That was wonderful.
Yeah.
All right, our next speaker is Dr. Yi Zhang. She will be presenting on unequal burdens, racial, ethnic, and sex disparities in chronic pancreatitis-related mortality, a nationwide time trend analysis using the 2000 to 2023 National Center for Health Statistics database.
Thanks so much. Thanks APA, and thanks so much for the moderators and the audience stay in the late night, late evening with us. And Dr. Choate, thank you for the comprehensive review about an important area in CP. And I'm going to continue the talk in the field using database analysis for unequal burden in chronic pancreatitis related mortality. Yeah. Thanks. This work was done during my transition from medical pancreatology fellowship to junior faculty at Stanford. So I would love to thank my co-authors, including those from Cedars-Sinai, Rutgers, and Peking Union Medical College Hospital, and also Johns Hopkins. Thank you all for your help. We all know that chronic pancreatitis is a progressive fibroinflammatory condition that is associated with great morbidity and mortality. And with time, our knowledge accumulates regarding the chronic pancreatitis natural history. And I would love to share a Danish population-based cohort study published in Gastro around more than 10 years ago regarding a substantially higher mortality in chronic pancreatitis. This is a study included around 12,000 chronic pancreatitis patients when compared with age and sex matched cohort. And it was found that significantly higher risk for mortality was observed in the chronic pancreatitis cohort with a relative adjusted hazard ratio of 5. What's more important, it's around 8 years reduction of life expectancy was observed in this population. When we look into the different age groups, which is the lower portion of the slides, we found that mortality risk was markedly up in all ages. And interestingly, in those patients younger than 50 to 60 years old, when we compare the hazard ratio of risk of mortality in chronic pancreatitis patient versus control group, there is an even higher risk with a hazard ratio more than 10 times. And most recently this year, there's a new publication, the US data, utilized the US veterans cohort with more than 12,000 CP patients. It was discovered a similar finding that about 10 years reduction of life expectancy and increased adjusted hazard ratio for risk of mortality. Of note, during the 16 years follow-up period, around half of patients with CP died. And with extensive literature review, we noticed that there is a limited data on the temporal trends of chronic pancreatitis-related mortality in the last 2 decades. Part of the reason is probably because the hard of diagnosis accuracy for epidemiology data. And also, we noticed there's insufficient data on mortality pattern. That's why the aim of this study was to evaluate the race, ethnicity, age, sex, and specific time trends in chronic pancreatitis-related mortality in the United States between 2000 and 2023 using a nationwide population-based database, which is the NCHS. A little bit about the data source. And this is the CDC's National Center of Health Statistics database, which covers nearly 100% of the US population. Mortality data was obtained by the National Vital Statistical System. And US adult patients with chronic pancreatitis-related deaths were included in this study. We all know that chronic pancreatitis is usually regarded as an indirect or contributing factor of the mortality. That's why we included all chronic pancreatitis as one of the contributing cause of death in this database. Mortality rate was defined by the number of patients whose death was related to chronic pancreatitis per 100,000 population in a calendar year. And also this data is age adjusted or standards using the 2000 US Census population. A little bit about the definition. We're going to use annual percentage change, APC, a lot. This is a percentage change of chronic pancreatitis related mortality in between subsequent calendar years. And also we're going to use the average APC, which is the average percentage of the mortality rate change during the study period, which is a summary measurement of the trend. Age groups, we are using the cutoff 55 years old to separate older and younger population because there is epidemiology data showing that beyond this age, complication rates and mortality risk significantly higher. And also we are using 50 years old and 60 years old cutoff in the sensitivity analysis. In terms of the different subgroups of the racial ethnic groups, we focused on the non-Hispanic white, non-Hispanic black, and also Hispanic groups. We intended or attempted to do the trend analysis for the minority population, but there wasn't enough data for us to do the trend study. Statistical analysis wise, we're using the joint point regression program for the time trends. Additionally, we're testing the identicalness and the parallelism about the trend to provide a comprehensive description. Bonferroni correction was used with a particular p-value cutoff 0.025 for subgroup analysis. And this is the first part showing the distribution of chronic pancreatitis-related mortality. There are a total of 33,000 population with 55% of men and 45% of women, and with the racial ethnic distribution showing most of the patients in this database are non-Hispanic white, represents 72% of the population, and 19.6% are non-Hispanic white, while around 2,000 patients are Hispanic, represent 5.8% of the population. When we look into the absolute age-adjusted mortality rate, and as you can see that, not surprisingly, old age is associated with a higher mortality rate, and also the blue group showed non-Hispanic Black population, a relatively higher absolute mortality rate. Next, we're going to switch gear to look into the actual trend, which is related to AAPC and the slope of the tables. I'm showing 3 different figures. Figure A is the trend between a comparison of non-Hispanic Black and non-Hispanic white for all ages, and old adults and younger adults in this. The x-axis showed the year trend, and the y-axis showed absolute age-adjusted mortality rate per 100,000 population. And if we look into the non-Hispanic Black, we find that consistent negative AAPC with statistical significancy basically showed a consistent decreasing trend of mortality in non-Hispanic Black during the study period, while for the non-Hispanic white, their AAPC showed a positive number. It's towards uptrending trend, but didn't reach statistical significance. That's why we call it stable trends. Here is a busy table. I would love to take some time to explain the red box part. It's a comprehensive description about the trend analysis. You can focus on the gray part, and we're calculating the AAPC for each trends. And also when we compare non-Hispanic Black and non-Hispanic white, we're calculating the AAPC difference with a p-value. And also we're checking the p-value for coincidence and a parallelism. When the p-value is significant, meaning coincidence is rejected, parallelism is rejected, we're reporting the data as significant AAPC difference with non-identical and non-parallel trends. The second comparison was about non-Hispanic white and Hispanics population. And same thing, when we see non-Hispanic white, it's a slightly up towards uptrending, but didn't reach significance. We call it stable trends. In the Hispanic population, we see a negative AAPC, basically showed a slight towards decreasing trend, but didn't reach statistical significance. So both showed stable trends, but with significant AAPC change. A little bit more exploration in the gender disparity. And actually, there are not much sex disparity in chronic pancreatitis in most of the ethnicity, racial ethnicity, and age groups, except in the young Hispanic population, which showed in the red box, and where young Hispanic men showed a consistently decreasing mortality trends, while the young Hispanic women showed a relatively stable trends. And this is a conclusion of the study. Using a nationwide population-based study covers nearly 100% of the US population. We showed an age-adjusted mortality rate trend is consistently decreasing in the non-Hispanic white Black population, while showed relatively stable in the non-Hispanic white and Hispanics population with different AAPC difference. and significant disparities is showing in the young Hispanic population. We used the sensitivity analysis to test the cutoff age of 50 and 60 years old and found similar results. And this is a database study. There is some inherited risk from ICD code identified case. And also we noticed limited ethnicity diversity and lack of clinical covariance makes it's difficult to explain what have been causing this disparity. But our future directions would be look more into the etiology-based subgroups and also geographic variation and also cause-specific mortality. I think we'll continue work on this field. Thank you so much.
Any questions from the audience for our presenter? The mic on up here? Right now.
Yeah, this is an important question. In most of the database that we're trying to investigate, it is identified by the ICD code. It is inherited limitation from the population-based database. Thanks for pointing that out.
Okay, thank you.
Thank you for very nice study and nice data. Your results are clearly showing that there's very significant decrease in mortality in Black males, but not as much in Black women. And it's not much change in white population. Why is that?
Yeah, I believe this is multifactorial. Actually, Dr. Cho's presentation provided great hints for that. I believe social economic status is one of the important factors. Also, environmental factors like etiology-based study like alcohol use or smoking or different etiology proportion in different racial ethnicity groups. That's what I'm thinking. Obviously, there are other causes and maybe certain intervention related to certain groups or etiology-based or ethnicity-based groups really helped with decreasing trend in the population.
Just to follow up, I mean, if it's a social economic situation, then it should be very similar to males versus females because they live in similar circumstances. And actually, in pancreatic cancer also, the mortality rate is decreasing for Black males, but there is not much change in Black females, very somewhat similar to your data in chronic pancreatitis. So I always wonder, why is that?
Great question. Yeah, I believe there is some inherited like sex-based difference or imbalance in different populations as well. And in this, actually for this study, the sex disparities is not that obvious, only showed in the Hispanic population, a younger Hispanic population. Thanks.
Right.
Yeah, I missed the first part of your presentation, but I'm interested in hearing if you were able to look into food insecurity and if that has any impact on the natural history of this disease.
Yeah, thanks for bringing that up. That's definitely one of the important factors. But for this database, we're not able to explore that part, but I do understand there are many groups working on this. I would be definitely pay attention to the outcomes. Thanks.
Thank you.
Well, it's really a privilege to welcome Dr. John Crothers, someone I have known and admired for more than 20 years and followed probably for 30 years. Dr. Crothers is the Vice Chancellor for Health Sciences at UC San Diego, where he oversees whole UC San Diego health system, School of Medicine, public health, pharmaceutical sciences. he obtained his MD from Wayne State and then did his internal medicine residency in Michigan, University of Michigan, and then went to Harvard in MGH to do his GI fellowship. And if I'm not wrong, then came back to San Diego for eventually became chief of gastroenterology, and pretty soon went back to Michigan as chair of medicine for almost 13 years, starting 2011 onwards, among which he really dramatically expanded that department. He was senior associate editor for gastroenterology and until I think 2016. And I remember towards the end of 15 going to your office to get training to be an associate editor for gastroenterology, which I started in 2016. So in 2022, he came back to San Diego as a vice chancellor for health system. Not only he is really a very astute administrator to run huge UC health system, he has really significant research in colon cancer genetics and colon cancer disparities among different populations. Hopefully he'll tell us a little bit about that. He's been continuously funded for 30 years from NIH, focusing on DNA mismatch repair in colon cancer. Dr. Crothers has been past president of American Gastroenterology Association, huge organization, and past president of Association of American Physicians. And he's currently on board of directors of AACR. John is member of National Academy of Medicine and American Academy of Art and Science. I can go on telling more about him, all his publications and work, but that's not the aim. So John, welcome.
Thank you so much for the introduction. I have to apologize. I have a little bit of laryngitis, so I really apologize for that. I'm actually on the upswing because you should have heard of me yesterday. Thank you for that wonderful introduction. It's great to be here at the American Pancreatic Association, and I hope I can impart some of the craziness that's been going on with our federal government and how it's applied to our academic health systems. And so I'm going to first just show you, these are my disclosures. And my outline is, I'm just going to briefly go over my role, and I think it was a really aptly applied in the introduction. Then I'm just going to tell you about the current landscape and how it affects every aspect of my role. The real reality, despite what is said out there, of how illness and disparities are going on, and then some potential mitigations. I don't have all the answers, but some of the things that we're trying and other people are trying. So first, you heard some of my roles, so I'm not going to spend any time on this. But my role is I do report to a chancellor, and I'm in the UC system. UC is 10 campuses, one president. Each campus has a chancellor. So I'm one of the 3 vice chancellors at UC San Diego. The other ones are the head of Scripps Institution of Oceanography and for academic affairs. It's unusual because most campuses have a provost in which all the deans report to them. We don't have such a system. So I have 3 deans that report to me and not to a provost. Then SIO has 1 dean and academic affairs has 8 deans. So I have 3 deans for medicine, pharmacy, public health, and then the health system CEO. We're about a $5.4 billion health system right now. The other thing is that the major institute and center directors report to me. So they're on the level of like a dean. So the head of our cancer center, the head of our CTSA, et cetera, also report to me. My role is I distribute state FTEs to the deans underneath me. I distribute indirect cost to the deans underneath me. I oversee research space and academic space. So I have a space committee at my level that oversees pharmacy space, public health, etc. I have a subgroup under advancement that's in health sciences. I have a subgroup for IT and data management. Academic and faculty affairs, which is at most schools, is at my level. So our academic faculty affairs covers 3 schools. So it's a little bit different structure. I also help coordinate many of the campus interactions, and I coordinate with our partners. So we don't own a children's hospital, but we have an affiliation agreement with Rady Children's, our VA, and some of the other institutes that are on the Mesa. I also have a weekly meeting with my counterparts. There are 6 medical schools and 5 health systems in the UC system, and we all meet Friday at 7 a.m. on a Zoom and talk about things. We have a impending strike starting Monday, so we were discussing that. We deal with 12 unions, by the way. And then I also liaison as part of my university with our regions. We have one board of regents that covers all 10 campuses. So I just wanted to tell you that because as I lay out the landscape, every aspect I just told you is going to be affected. So what is the landscape? Most of you guys know what's going on out there. We have a current administration that is aligned with the same as the same party at the White House, the Senate, and the House of Representatives. We've had multiple executive orders written. I do want to mention executive orders are not law. There are 4 major, I'll say DEI laws on the books that go back to 1866. None of them have been changed. None of them have been renewed or affected. These are all executive orders. They do not have to force the law, but they do have to force how to direct the administration on how to theoretically administer the laws. Our House and Senate have been lockstep with the executive branch, and the Supreme Court tilts with that same party. So that's why everything's certainly aligned for all these things that have come up right now. So I mention that because what are the challenges for an academic health center? Currently, if you look at all large academic health centers, for most cases, income from insurers for the care of all of you that comes into a hospital or an outpatient clinic are not keeping up with the cost of inflation and labor costs. I just mentioned I have 2 or 3 unions threatening to strike on Monday, and they will. We've already spent money on replacement workers because we have to fly them in. And our inflation is high. Everyone has experienced that. But the labor costs, and I'll say maybe this is not necessarily unique to California, but have been going up much faster than insurers are paying hospitals and other caregivers for care. We need to be competitive. We still need to be competitive. So the strategy has been, grow the clinical volume, have some innovation. You can grow clinical trials, also that tracks some patients as well, and also continue your pipeline. We are a little different than a regular nonprofit, for instance, hospital or outpatient center, because there's transfers of money for supporting faculty for research. That's what builds the reputation of an academic health center. So most nonprofit non-medical school associated places don't spend a lot of money on research, and so they don't have to budget that into their systems. So we've been using avenues to make up for tight clinical revenue streams. Again, increasing volume, expense reduction, philanthropy, royalties, mergers and acquisitions, which in California, that has been the big explosion over the last 5 years with the threatened closure or near closure of many hospitals in and around even urban areas, suburban areas, and certainly rural areas, that several of the UCs, which we are the only public institution that has health systems in the state of California, have been purchasing or partnering with these hospitals. And I can tell you in my own case, we bought a hospital near San Diego State University just under 2 years ago. And we just signed a joint powers agreement for another public health system, I'll say a public, but not medical affiliated health system that was underwater. And that deal is nearly done, but it has to be approved by the state of California. And then also making investments into that. What about mitigating all this? And this is a little table I borrowed from my own CEO. There's things going on at the state, the federal, payer competitor activity, technology, and cost structure that we're spending a lot of time advocacy at all these different levels because of all these different threats to many aspects. And this is just the clinical list largely. There is one bill that is not a DEI bill that was signed into law on July 4th that cuts 1 trillion, that's trillion with a T, to the Medicaid program. And that was designed not to commence until after the 2026 elections, so it wouldn't influence it theoretically. That law changes eligibility and enrollment for Medicaid. It puts a lot more barriers for people to get on Medicaid and stay on Medicaid. It lowers limits to Medicaid state-directed payments. And in our case, that's a hit of about $23 million annually. It lowers limits on Medicare provider taxes, and it changes the FMAP program, which is big in California because we have several non-citizens who are here legally, not necessarily illegally, but it changes that payment down, that match that from 90% to 50%. We feel that that's going to hit us probably up to 25 to $30 million. This is only on the surface because there are people who can't get insurance, even CMS insurance, and we expect that the uninsured is going to show up more in our emergency rooms, even though our emergency rooms are already filled, which is going to hit us probably by another 30 to 50 million or more. So this is probably an underestimate just for our institution. It also changes the pipeline. So the loan programs that people go to professional schools and undergrad schools are going to be affected because now there is a cap. There's a cap when this goes into effect on how much someone can borrow to go to medical school or pharmacy school. And that limit is $200,000. It also dictates the only 2 ways that it can be repaid. And so we did a back of the napkin calculation of our students in our medical school. And we estimate somewhere between 15 to 20% of our students would have to go to the commercial market after they borrow. And we're a state school. So I don't know how that's going to affect a private school. And so that means they're going to have a choice. They go to the commercial market where the rates are much higher, or they don't go to school and they choose something else. And we already have a shortage of doctors. the executive orders have done a lot of different things. Our contracts and grants, and this is all across the country. It's affected if you were doing research work, some of the beautiful work that was just presented here might be considered DEI, and if it was NIH funded, it might not be NIH funded now. But DEI, gender, immigration, vaccines, and particularly foreign aid has all essentially been eliminated from NSF, NIH. Uh, this affects all universities. There was, starting in February, a huge threat to the FNA costs, or what we call IDCs, which I believe will get cut to some degree, maybe not as draconian as what was presented in February. Up until, I'll say, late August and September, there were delays in universities getting money withdrawals from the NIH for support. We were way behind. I mean, we were worried that we were going to go under as well, because at UCSD, we withdraw probably $50 million a month, because we have about $650 million in NIH funding a year. And you go 2 or 3 months without a withdrawal, all of a sudden you're $150 million in the red. And if it's never replaced, that's on your books, right? And then there's the penalties, which you've seen hit the news. What have we done? We've reduced one-time payments from my office. We've moved away from individual faculty commitments. That is now mostly at the deans and chairs levels. I had to pause 2 buildings. A research building, I left a big hole in the ground because I already spent $60 million on that hole and design, because we don't know how the indirects are going to pay for that in the future. We've had a hiring pause for major scientists. We have not paused hiring for clinicians. We've done a non-essential spending freeze. We've had an FTE distribution freeze. The FTEs are mostly from the state. Some of them are intrinsic. But once we assign it to you, it's with you until you retire, die, or leave the institution. And so that money is tied to you. So if I don't spend it, it's not tied to you. So we will fall some of these things once we figure out what Congress is going to do, other than another continuing resolution until January 30th. What has our School of Medicine done? They've slowed down also on research hires. They've targeted some staff reductions. They've reduced some costs for PhD education at schools. They've blocked subsidies for some of our postdocs. There were some other support mechanisms. They've reduced some operational transfers to departments. They've have to use some of their own discretionary money, and eliminate some of these legacy things that were in the schools. Now, what's the outlook for some of this? And I will get to a lot of the DEI stuff coming up, so don't worry. This represents 2 of the 3 branches of our federal government, the executive branch and Congress. The executive branch put out a proposal in, I believe it was April, that they wanted to author a 40% cut in the NIH budget. Fortunately, Congress and both appropriation committees in the House and the Senate are a little more reasonable to at least academic medicine and medical research. Both have either kept about the same or with some minimal increase, without a dramatic change in FNA or IDC costs. Now, the government shut down October 1st. They just reopened. So none of this has passed yet, other than the current continuing resolution through January 30th. So all I can say now is through September 30th, they didn't cut the FNA costs, and through January 30th, they have not cut the FNA costs. So and in my role, I do depend, and our university depends, and all of your universities depend on those FNA costs for a lot of infrastructure. The other thing is the targeted events that have happened at specific universities. I've kept track of all this. So this is the current list of all the universities and how much money they've had frozen. Almost all these universities are private universities. There's no state attorney general, no governor behind them, except for Maine, because Maine just pissed off the executive branch. The governor did. And then until UCLA was hit on August 1st. And you can see this totals up to billions of dollars out of academic, or I should say universities. And the reasons have been variable depending on the university. And this all started back in the spring. In the case of UCLA, which is one of my sister institutions here in part of the University of California, they had $584 million frozen on August 1st. And it was fascinating. And talking to my counterpart, which I kept in pretty much constant contact because we feared we were going to be next, they did surgical strikes on their grants. That probably was not very public because I think they learned some lessons from what they did at Columbia and Cornell, where they just blocked everything or blocked. I don't know who's making these decisions. Probably some 32-year-old person in someone's office, as I'm guessing in the Department of Education, is making these decisions, but I have no idea. But in the UCLA's case, which was just one of the later cases, they targeted all the training grants, the Fs and T grants, and most of the basic research grants. They left almost unscathed anything that had to do with clinical research, probably because they did not want to totally piss off the community and patients, because that would incent more than just the university. That's how they structure it. Now, the good news, it lasted 60 days until a judge released 500 million of the 584 million, okay, for UCLA. Now, there have been settlement proposals also put by the federal government for the universities listed here. The University of Pennsylvania probably got off the easiest because there was no money involved. They just had to change their athletic records because they didn't like some swimmer that won a race 4 years prior. Columbia gave $200 million back to the US Treasury and $21 million to settle a class action lawsuit for quote unquote anti-Semitism. And they agreed to an outside monitor. That's the only university that's ever agreed to an outside monitor. Brown was a little smarter. They don't own a hospital, but all the money they agreed to settle on stays in the state, which was probably smart. Harvard was offered a $500 million buyout. They refused, and they won a lawsuit, although there's an appeal on the lawsuit. UCLA, and don't ask me why UCLA was specifically picked out of 10 campuses for $1 billion. Why is that more? Why was it way more than Harvard? I have no idea. To going back to the US Treasury. And of course, the regents, which represent 10 campuses, felt if it was $1 billion to UCLA, is it going to be $10 billion to the whole system? But they refused that settlement, and the judge ruled it was in violation, although there's ongoing appeals. UVA, which was not on my original list, didn't have any funds blocked, but they forced out their president after some support for some DEI programs. And they had a settlement on October 22nd that changes the way they do some things, but they agreed to no monitoring or no payout. And Cornell just settled on November 7th for 60 million, of which 30 million goes to the feds and 30 million goes to research for farmers. I don't know why that was picked, but that's the deals that were out there. There is one other pact, and this is still the landscape. there's a pact from the federal government, the executive branch, with that is asked initially, I believe it was 9 universities, and then 3 more were added to have special access to federal funds in exchange for a whole bevy of consequences. In other words, if you freeze your tuition for 5 years, what university freezes their tuition for 5 years? Reducing administration costs, maybe that's a good thing. Um, if you have a certain amount of endowment, you have to waive tuition for people going into hard science. I assume that means STEM, but I took the language directly out of the report. You have to quell grade inflation. I'm not sure exactly what that means. But probably the most thing was this becomes very political. You have to be more welcoming environment for conservatives and abolish departments that specifically blah, 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 blah. So in other words, they're doing an exchange for a competitive process to a political process. And of course, all the universities in red said, no, we're not going to do that. We'll stay competitive. Vanderbilt and UT Austin have not committed yet, and I have not seen anything from ASU, WashU, or Kansas to date. But if a university does agree to this, which is up to them, it is open-ended. There is no set date or anything. It, of course, affects their finances heavily, and depending on the size and scope of your tuition, it accepts your academic freedom, and it takes away scientific merit competition for federal funds. The other thing that's in the landscape, and we witnessed this with our CTSA grant, as well as our CCSG grant, is you have to avoid certain words in your grant renewals. Otherwise, it wasn't going to go very far. I say this because all the way up until this year, there were 2 federal political appointees of the NIH. That was the NCI director and the NIH director, and they had to get Senate approval. There are now 40 political appointees in the NIH, and that is creating a new layer to look for things that don't fit with what these executive orders suggest or indicate. And they could terminate for convenience. These are the new rules coming out of the NIH, in addition to removing any DEI language. But okay, so that's the landscape. Here's the reality. I'm going to start going a little faster here. I apologize. The reality is, if you look things by race and ethnicity, there are huge differences in comorbidities. You just heard some of this from the previous presenters. This is just data that was taken out around time of COVID, showing even as you go from 25 to 45 to 64 years old, in this case, Blacks have more than 1, 2, 3, or 4 risk factors, and the percentages change. And certainly by the time you're 65 years or plus, there's marked differences even with Hispanics and whites and Blacks. If you look at heart disease, one of the most common heart disease, this is just something I've taken off the CDC website, our own government's website. Huge disparities in percents of deaths, heart disease. What about diabetes? Huge differences. In both of these cases, more such in Black patients compared to white or Asians or Hispanics. What about cancers? And the story of the last 3 or 4 years is it was almost always highest in African Americans. But now that Native Americans are living much longer, almost all these cancer incidents are highest among Native Americans, Alaska Natives, except for prostate cancer. And the mortality is pretty much the same as well. And in my own field of colorectal cancer, this is not really a race or ethnicity, it's a surrogate for your environment. The biggest predictor, and I'll show you this on the next slide, is the zip code you're born in, your environment, what the resources you have, what you're exposed to. That has downstream consequences of how many grocery stores per square mile is near you, how many parks, what's your ability to get educated, job, etc. And certainly for someone in gastroenterology, as many of you are, it certainly has changes by the type of things that you eat. This is over your lifetime. And and then that is what changes your risk. Has this ever been proven? Well, there has been plenty of data, and this was just one recent one that came out in JAMA Oncology, looking at what were the drivers of disparities between some certain races and ethnicities. The biggest driver was this air deprivation index, which is your zip code. Okay. And some other things went into that, your marital status and everything. But almost a third of any disparity is the zip code you're born in. I also see this in prevention. So since I work in colon cancer, I'll take the liberty of showing a couple slides on colon cancer. You know, this is pancreas. In screening for colon cancer, one of the biggest things that are done in GI, there's still disparities whether you use colonoscopy or just look at overall screening. And the difference can be explained, some of it by age, your immigrant status, your status, your college education, and your insured status, which is, again, some of these surrogates. The exception was for Asians. For some reason, it's been persistently lower for getting a colonoscopy amongst Asians. Again, this is a study out of Kaiser showing that with navigated fit, which is not even colonoscopy, that navigated fit not only afloats all boats, but eliminates disparities. So this is by my friend Chaik Dubaini, who on the left is a graph showing that before this study happened, most screening rates were around 40%, and after the study rate, it's doubled it to 80%. But no matter how you looked, whether you looked at early stage or late stage colon cancer, overall incidence or death from colon cancer, by the end of this 10-year plus study, if you have navigated fit and good participation, you can eliminate disparities. What's the reality on physician training? This is data just pulled out of the literature showing on the left. So the bar is showing by the proportion of US population, and the graph shows the level of graduate students, PhD, postdocs, faculty, and what is that relative to those populations. And you can see that for many of the characterizations that we place in race and ethnicities in the United States, they don't meet that. And then this small graph was specifically look like Hispanics and Black PhD recipients. The graphs do show a positive trend over the last 15, 20 years, but look at the y-axis. This is all under 10% of all PhD graduates. What about comparing the physician workforce? So on the left is the US census showing that Latinos make up almost 19% of US population, Blacks 12%, Asians 6%. But in the middle, Asians make up 19% of the physicians, Blacks 5%, and Latinos 6.5%. This is taken directly from the AAMC and the census websites. What about faculty? Many of you are faculty in this room. And so I had to put the percentages on the side and do all the calculations. But the percentage of Black faculty is about 4%. Percentage of Hispanic faculty is about 3.6%. And that's much lower than the US population overall. What about, okay, your faculty, what about your funding for NIH? Huge disparities. And this was first highlighted during Francis Collins' turn at NIH. So you can see the funding levels. This is supposed to be about science, but it doesn't always equate to that. So this is a study from the Government Accounting Office looking at the NIH-funded workforce, and you can see the differences at the different levels based on race or ethnicity. So huge differences. And this is a reference to a paper I published back in 2019, looking at just at the GI workforce. Oncology is on the left, but the same thing is showing on the GI trainees and faculty on the right, where there's very little fluctuation of the very low levels of Hispanic, Black, or Asian or Pacific Islander trainees. It's fluctuated by 0.02% over 10, 15-year period. You can see the GI faculty at the top. It hasn't really changed at all. Excuse me. The other complicating factor is how long does it take to get funded? Where the age of the first R1 now is now in mid-40s. And even though this data doesn't show much difference between gender or race or ethnicity, there have been, during some of the data collection years, there was some differences. So the other complicating factor is this. So I just took excerpts from this article when this came out about H-1B visas. And this was quoted from the AMA, which already knows in a state that we have a shortage of 80 to 100,000 physicians. And this could be a huge problem depending on how long this lasts. 1/4 of our physicians are international medical graduates. Excuse me. So if this lasts too long with already a shortage, this is going to be a big problem on top of everything else. So what are some of the potential mitigations? So this is the last part. I don't have all the answers, but I'll show you some interesting. First, for the academic health centers, they have to grow their revenue streams. So, and we're doing this, and I'm sure many others are doing it. Subspecialty enhancements, even though we need way more primary care. Forming networks, investments in reclaiming IP, although that's a current battle for some things. Excuse me. I'm actually on the upside. It was bad yesterday or two. More mergers and acquisitions, assuming there's money in the system to do that. People are pushing philanthropy, but we're also in a time where philanthropy is a little bit tighter right now. It may open up to, and also the battle with insurance companies, which fund much of the clinical care at academic health centers. I want to point out some of the work that Scott Page has highlighted and has been part of his career. Some of his data goes back to the 1990s and 2000s. So I don't know if any of you've seen this book, The Diversity Bonus. So Scott Page is I believe in the business school at the University of Michigan. And he has, thank you for a little bit of water. I'll take some. Thank you so kindly. It's better. Thank you. That helped me. But he has done a number of work on the success of businesses. And the businesses that thrive tend to have much more diverse input into them because people work on solutions from different angles based on their different backgrounds. In fact, I remember I was in a room with him, and he did this study. He took like 12 MIT professors and gave them a problem. They all solved it the exact same way, and it took them, I don't know, a couple hours. I don't remember exactly what it was. Then he took 12 different people, which only one was an MIT professor, and he had a grocery store person, a housewife, and a different type of professor. They figured out the problem a little bit faster, and it was a much more durable solution. And so this is diversity of input into the success. And I think it's one of the beautiful things that has sustained us for our country for 250 years is that diversity of input. Now, just having diversity doesn't mean you're going to have discovery and innovation. No, I don't think anyone is saying that. There's a lot of things that go inside that help direct that and pull out those innovations and pull out those aspects of each person that contribute to that discovery and innovation. And this was just a diagram I took out of an article in PNAS about some of the things that have to happen in the organizations, many of which are actually being dismantled today. This will blow your mind, this study. This study came out in Nature Communications about 5 years ago. This group looked at what was the driver of higher citations of your science. Everyone's ears perked up here. Okay, 6 million scientists, 10 million articles, and the biggest driver for higher citations was actually ethnic diversity. Can you believe that? This is Nature Communications. It didn't matter on the year of publication, because they looked at a finite period. It didn't matter the number of authors per publisher or the number of collaborators. And on the left, on the real data, you can see that dark blue line that showed the higher citations based on that diversity, whereas on the right, as if it was randomized, the lines would have been overlapped. And what was the breakdown of that diversity? It was actually group diversity. So different people solving problems, which must have put out a better product and led to more citations. Okay, so the result showed almost 11% impact gain for each paper and almost a 50% gain for the scientists based on that group ethnic diversity. That just blew my mind when I saw this. The NIH in particular and the federal government have put out many programs to help support some of the disparities in some of the things I talked about. This was from an NLHBI workshop a few years ago and maybe a decade ago, looking at how to overcome certain barriers for certain populations who might be interested in science and eventually becoming an NIH-funded person. And that include cost of living, because many people come from different zip codes. Some people start families at different stages of their life, even just exposure to science. And so they created a number of programs. These are some of the programs that were established. Some of them are not established now just because of changes in federal policy. But the MARC program, MBRS program, you might have heard some of these programs at several campuses. Research infrastructure in minority institutions, high school programs. You can see a whole list here, and I'm happy to share this with you. Keep in mind, there are no new DEI laws. And I keep hearing this term that people talk to me like, you're the vice chancellor, you can't do illegal DEI. I said, tell me what illegal DEI is. Because if you tell me what legal DEI is, you're defining something, and then I'll know what illegal DEI is. We have not been doing any illegal DEI. It's just interpretation. In California, we've had Prop 209, which banned the use of race, sex, gender identity, all this other stuff since 1996. We've always abided by that. There's not been any new law since then. But I want to say, for particularly training individuals, we have to push that. These are our future people, our future leaders. There are a lot of barriers right now, everything from H-1B visas, now caps on funding for your education and those types of things. That's going to curtail already the shortage. And let alone, remember, only a small percent of those stay in academia. Again, I want to remind everyone, diverse trainees from various backgrounds bring diverse ideas to the table and actually improve discovery and citations. The last thing I'll say, what else can we do? And some of these things are going to be on us. Can you apply for F-31s and F-32s with the right language? Because some T-32s are getting canceled. Sure. We were fortunate to get our CTSA renewed, which has a KL2 program. So I'm steering a lot of people toward that. We've been pushing philanthropic funding, although you have to get that funding. So that's a big push. I'm about to start a person in my office who's just developing relationships with industry. And we supply a lot of their PhDs as well as their MDs that go into industry. Foundation funding, some of them have stepped up to the plate during this crisis. We were fortunate we got $1 million from the Presby Foundation just because of this crisis, no questions asked. And we gave $20,000, $50,000 grants to many of our young scientists just because of that donation. We're trying to see how we can do some internal funding as well as partner funding. But the key is we definitely have to support the commitments that we've made, and we have to keep that pipeline going and encourage the future of training. And the other thing we're looking into is, I have probably over 100 H-1B visas, ranging from students to faculty. And now I gotta, if they were all new, I can't afford 100,000 on each one of those. So we're gonna have to limit that. But people can still come on other visas that don't have those heavy financial fines. So I'll stop there, and I'm sorry I went a few minutes over, but happy to take questions. Sorry for my voice too.
Thank you. Thank you so much, John, for very thought-provoking and intense with thoughts presentation. I'm sure we have many questions. I certainly do want to have some, but I think what we're going to do is we have a reception outside so that we can have some drink and some food and we can talk outside. Thank you. Thank you so much again.
Thank you. Thank you for inviting me.